Hi, I'm Dr. Yusuf from Cornwall, Ontario, presenting to you this bilateral simultaneous femto laser cataract extraction taken by 360 Max GoPro with the Hero 8 GoPro and the Microscope camera at the same time, certain stages. So we're setting up the patient on the laser bed comfortably. It's very important for the patient not to move during the laser procedure. So we have to make sure that the patient is very, very comfortable to make sure of that. So we're putting a strap on the head so it stabilizes the head throughout the surgery. And I usually do that with the laser patients and without the laser patients. So I don't like surprises. Putting a wedge underneath the knees of the patient would help a lot to relax the back and make the patient much more comfortable. So this is Kelly, the laser technician, getting the patient ready for me. And on the left side, this is Frank, my scrub nurse, is getting the surgical tables ready. So Kelly now is putting the tubing for the LOI, liquid optic interface, that attaches the suction ring to the patient's eye to stabilize the eye throughout the surgery and holds the lids open. Frank set up the table for the first eye, and after that he will set up the table for the second eye. Completely two separate setups for each eye, of course. Kelly, what he's doing now, he's adjusting the patient's level and location to be underneath the laser. So once we put the suction ring on, it will be the shortest time possible because we already did the adjustments from before the starting the suction. So he's adjusting the LOI, the tubing. It's not always easy to keep it in place, this LOI tubing. They changed the format of it, so it's not very stable on that area. So now I came in and just helping Frank to close his gown and adjusting the computer. Kelly now is wetting the lens of the laser. When you wet the lens of the laser, you break the surface tension of the air bubbles, so you don't get a lot of air bubbles during the procedure when you dock the lens and the LOI together. I'm putting the BSS solution, the tubing of the BSS solution, to connect it to the phaco so that Frank can start adjusting the phaco machine. I'm reviewing the patient's details and reviewing the plan for the laser and starting the laser procedure. So at this stage, I ask the patient to look at my forehead to adjust the location of the eye. I dry the skin out around the eyes so that I'm able to actually hold the lids open, because the jelly from the freezing usually makes it very slippery. Now putting this suction ring on. And I started suction. Now Kelly's filling the LOI with saline to fill the space and bring the patient underneath the laser. And Kelly has locked the laser bed in place so it doesn't move, and I'm going up. You can see on this computer monitor now the patient is docked. And the scanner will start after the capture and locking the two mechanisms together. The laser will start scanning the different layers of the eye. So scans from front of the cornea, the back of the cornea, front of the lens, the back of the lens, the pupil edges, and the limbus. So everything is scanned and tracked throughout the procedure. So I'm verifying the computer selections. Most of the time it's very good, and I just need sometimes to modify a little. Now the laser started with the rexes, the division of the nucleus, and then goes through LOI and incisions if they're programmed. So I'm putting my hand on the patient's head to stabilize the forces and give the patient comfort that I'm there for them and beside them. And usually throughout this part, I ask the patient not to move and not to talk, and keep talking to patients, give them feedback on what's happening, so comforting them. Because you can't move at this stage. Now I release the suction, and the bed will go down and rotate it outwards. So Kelly will remove this tubing and put the tubing for the second eye. Then move the bed up because it was down for the laser. I put it up at maximum. You can see the GoPro, the Hero 8, attached to the microscope with 3D printed arm. I'm just adjusting the GoPro.
You want to start left here? Oh no, I guess you did it right, eh? Okay.
So now I'm gonna get ready for the procedure. I'm gonna scrub. And Frank will have me put my gowns and gloves on. I'm starting the first table. Meanwhile, Kelly is switching the sides. So he's putting the setup for the next eye for later.
Not yet. No. That was just
Lynn was scrubbing the eye, cleaning with betadine around the eye. We put betadine drops before the surgery to sterilize the conjunctiva, and now it's sterilizing and cleaning up the skin. Now I'm putting the drapes on. They stick on, so they stick around that eye, cover the mostly on top of the eye because of the on top of the head, because the bed for the laser has the joystick on top. So I actually put this drape upside down, so the more length you have is toward the patient's head. Normally it's designed to be the other way around, but I modified it for laser cases to cover that joystick area. I'm opening the drape, so the upside of the drape, and I'll put the speculum to hold the eyes open. Again, this is almost an unedited video, so there's a lot of steps that I could have taken out, but I wanted to give you the full view of the procedure so that it's not just completely ironed out from all the steps. I'm just putting all the steps in. I use 2 Ziplocs to adjust the microscope. Put them in place. Now the microscope view is going to be on the bottom left, and the GoPro is on top left.
Okay, that's good. Thank you.
Okay.
That's good.
So I'm just adjusting the microscope again. Now we'll get rid of the zip lock. Now I'll start the surgery while Frank is preparing the second eye.
Doing great.
And now we're going to start the surgery on this one here. The lens is opening the lens on top of the, this is the Eyhance lens, the one that gives you distance and intermediate vision. So I'm opening the 2.7 millimeter incision at the top of the temporal part of the cornea. Now I'm injecting the xylocaine with a phenol in, and I'm using Endocoat to fill the chamber and cover the cornea. At the same time, I make sure that the recess is complete because it was done with the laser, but I just want to make sure that it's completed. So I move the cap and then cover the cornea. I'm opening the second incision now. It's usually end up like 0.9 millimeters, and I put it 80 degrees to the left of the main incision. So I'm doing a hydrodissection at this stage, and with laser cases, remember the lens is already divided. You have to do the hydrodissection every quadrant separately because there is no continuity now that the lens is divided. So you have to be a little bit modifying the technique you do the hydrodissection and hydrodelineation at this stage. So I'm starting the phaco. This nice lady has Fuchs dystrophy, so we wanted to use the least amount of phaco possible to preserve the endothelium. And that's the nice thing about the laser, is that it makes us use much less energy to remove the cataract without damaging the endothelium. And in these cases, we have to make sure that the endothelium is well protected throughout. So I make sure that the anterior chamber is completely full with Endocoat. And you can see that there's air bubbles on the sides. The air bubbles are not moving at all. It means that that area, there's no turbulence, nothing is touching this area at all. And of course you don't see 3D, but in 3D you know that these air bubbles are not reaching the cornea. Means that they are not, there's a layer preventing them from reaching the cornea, which is the Endocoat. So this way you make sure that it's the Endocoat coverage of the endothelium is complete. So phaco went really well. So go out with the chopper first, stop the infusion, and then withdraw the phaco handpiece. And in that sequence. Now I'll use the J cannula to clean up the capsule without having to do irrigation aspiration at this stage. And I want you to notice also that the air bubbles are not moving. And these air bubbles are behind the Endocoat that's covering the cornea. So there's no turbulence at the corneal level at this stage. It's all just happening in the bag, and it's going, everything is coming out through the wound along the shaft of the J cannula. Now that the bag is cleaned, I'm gonna fill the bag and the chamber with Helon. And these lenses are pre-loaded, so you just have to inject them after putting Helon along the lens and the injector. So this is a very nice designed injector. It's much easier to use than the older ones. And be careful when you implant those lenses with the injector. Make sure that you don't put a lot of pressure on the bag, because I had an incident that for a small eye that actually the lens opened the capsule nasally during the injection process, because the white was too small. Now I verify the white diameter in every case just at the beginning as I check the lens power on the IOL master or the lens star. It's written what's the white, and I verify every single one of them to make sure when I'm doing this I know what size is the eye and expect what size is the bag, and make sure that I don't put excessive pressure on that area if the eye is too small. So I'm positioning the lens and using irrigation aspiration, not irrigation, that's sorry, the BSS to wash out the chamber. And I usually direct the irrigation BSS to the angles of the anterior chambers to make sure that nothing is hiding in this area. And then I'm doing hydration with the antibiotic, the amoxifloxacin. Hydrate the wounds with that, spread it throughout the eye inside, and wash the cornea with it, and flush the eye with the antibiotic. I'm going back with the BSS, just making sure positioning the lens properly, and I'm very picky about the centration of the lens. It has to be completely covered by the rhexis all around and very well centered. Checking the pressure and then re-injecting some of the antibiotic because the BSS washed some of it out. The nice thing about the intracorneal injection of the antibiotic is that even if it washes it out, you still have a lot of antibiotics in the eye. That doesn't wash out really quick. The intracameral part of the antibiotic just washes out quickly, but the intracorneal part doesn't. And I do the dropless injection, so the Primoxy is injected in the subconjunctival space, not in the vitreous. And this way the vision is clear and can be reversible if the pressure goes up. So when we're done with this eye, now we're going to change everything. So this table is going to be out. The next table is already prepared, so Frank is tearing out this one, and I'm going to start working on the laser part of the other eye, the left eye. Kelly came in, so he'll help me out with the laser part while Frank is taking care of the phaco, adjusting, switching the foot switches, and while we're getting ready on the laser on the left side. So Kelly's attaching the tubing again. It's a new setup, of course. Nothing in bilateral cases, nothing crosses from one eye to the other, and this is very, very important to avoid any kind of possible bilateral complication from anything. So we have to make sure that nothing is crossing from one side to the other. And when Frank prepared the first table and went to the second table, he will not touch anything on the first table that has been touching the patient and go to the second table. So nothing that he would touch that touched the patient. But when he comes back, it's okay now because he's gonna unscrub and scrub again. So Kelly's adjusting the laser, making sure that's set up for the left side so that we decrease the time when we put the suction on, so it'll be the minimum. I'm wetting the lens to make sure that we break the adhesion, not the adhesion, surface tension, sorry, to avoid air bubbles as much as possible. Although start still happens sometimes, but it's the incidence of air bubbles is less. So I'm putting the LOI on, and then Kelly's filling the LOI after I start the suction, and I'm moving the patient underneath the laser. You can see the eye of the patient on the laser. Kelly has to lock the bed in place so the bed doesn't move at all during the procedure. And now I'm adjusting the eye, and then, okay, here I go, air bubbles. Okay, so what I'll do, I'll just, sometimes you can dock on, undock, dock, undock, and they stay there. So what I do is just with my finger, I just wipe the lens from those air bubbles, and they stop happening. Now I capture and then lock the laser, and then verify that there's no air bubble and move on, so that the laser will start scanning the different layers of the eye. So the first layer will be the front of the cornea, then the back of the cornea, front of the lens and back of the lens, edge of the pupil, and the white to white. So the whole eye is scanned to make sure that we're exactly in place, and we're verifying these layers. Most of the time the laser has identified them very well, but again, we verify them. If we need to modify, you can just touch the screen and modify those. So it goes through the steps of the laser. Typically the suction time is about maximum of 2 minutes, usually around 2 minutes. Now the laser is done. Uncapture and then unlock and release the vacuum, and then release the bed, and we'll move the patient out, put the bed up, to the level of surgery. I'm doing it while I'm adjusting the foot switches. We multitask, of course, adjusting the oxyflex, adjusting the microscope all at once, so multitasking. So reassuring the patient about everything went well. So we're going to start the second eye. Lynn is cleaning up the eye with betadine. Again, betadine drops was done preoperatively to sterilize the conjunctiva, and then we're cleaning up the eye itself now, the skin around the eye. The nice thing about the 3D 360 Max is that you set up the camera somewhere, and you can actually recapture what you want to capture, because it's as if somebody's taking that video, staying up there and taking the videos. Can recapture that. Of course, you can see it as 360 video, but now it's edited. You can see that rotation of the camera. It's a very nice way to do it, as makes me retake or relive the moments if I need to. I don't usually use the 360 Max on these, but I just wanted to do it for one case. But I videotape most of or almost all of my cases through the surgical microscope. That's how we learn from our mistakes. So if something happens and you want to go back and review the case and see what went wrong, or to learn from it, or teach someone. So it's very important to videotape the cases, so that you can have a way to go back and restudy it, or ask one of your colleagues to look over what you did and see if we did a mistake, or teach someone too. So again, we're going to start the surgery now. The laser is done. We're going to remove the cataract and implant the lens. So I've put the drapes on. I'm putting the speculum. I open the drapes and putting the speculum on. You notice I'm not wearing a hat. It's a very redundant thing for me. I'm bald. I have no hair at all. I shave it once or twice a week. It's too shiny too. You notice that it's too shiny. I hope the reflection doesn't disturb your eyes. I'm verifying the lens, verifying the lens power, lens style, lens expiry date, and now I added the white to white to the verification step to make sure that the size of the eye is suitable, and if it's too small, I'll be extra careful. Sometimes I implant actually the lens in the anterior chamber first, and then move it very carefully into the posterior chamber, into the back, to make sure that I don't overstress the capsule or open the capsule like we did before. So I'm adjusting the microscope. So we have the GoPro view 360. Of course, this is the background, and then the GoPro, the Hero 8 is the top left, and the microscope view the bottom left. So starting the 2.75 millimeter incision, 2 millimeter deep temporal cornea, injecting the xylocaine with phenol as freezing and dilation, and then the endocoat to fill the chamber. Again, in this case, I have to be extra generous with it, filling the chamber, making sure that the back of the cornea is protected, the front of the cornea is protected by this one, and the laser cases, I verify the capsule X is complete during this step. Because I won't use capsule X force, I'm just going to go with hydrosection next. This is the 0.9 millimeter incision, 80 degrees to the left, and then this is the hydrosection, hydrodeletion, nuclear rotation, and here in the laser case I have to verify every quadrant to make sure that it's dissected well. The air bubbles will come back out from the inside the lens as we go. I rotated the lens, made sure that every quadrant is hydrosection. Makes your next steps easier. And here, especially in the few cases, I want to make sure that I don't spend too much time inside the eye. So we do this to make it shorter as possible. So the nucleus is already divided. So what I do, I use the chopper to pull it sideways towards the chopper while holding the quadrant with the phaco tip. It's a little different than what you would do in normal cases. So the direction of your chopping is different than the normal cases. Here you pull the quadrant sideways rather than centrally, like you do in normal chopping cases. Because it's already chopped, you just want to pull the parts different parts apart. The nucleus, this is the last part of the nucleus. You have to be very careful of these stages, because if the chamber collapses, you can open the capsule. Now the epinucleus is gone. Again, chopper first, stop the infusion, then pull out. The J cannula again. This design of J cannula I designed myself. It's I made it like a swan neck, so the direction is a little bit away from the axis of the J cannula, so that helps reach the areas that you can't reach. At the same time, I made it smaller, so it can actually pass through a smaller incision. So if you have a 2 millimeter incision, it can still pass through that. My incision is 2.75, so I'm not too worried. I'm refilling the cannula, J cannula. So never run out of BSS in the J cannula. If you're running low, don't try to go to the last drop. If you go to the last drop, the last part will be a suction, and you can end up with something that's captured by the J cannula inside, and you can't release it because it's sucking it because the last drop is gone. So never run out of BSS. So if you're not sure, just come out, refill, and go in again. And I'm filling the bag with Helon, and the lens is preloaded, and Helon is put around it so it doesn't stick together.
Great.
And I'm injecting carefully. Again, be careful with the size here. White was normal, so I'm not too worried, but again, be extra careful. But if sometimes you can put a lot of pressure on the nasal capsule. The lens is in, opened, and I'm removing the viscoelastic, the heel-on, and using the lens as a shield to do the irrigation aspiration safely without capturing the capsule. I came out and use the BSS to center the lens, wash behind the lens. I always go behind the lens with no irrigation aspiration, just with the irrigation, and this way you can capture areas that you don't see and remove everything from behind the lens safely without capturing the capsule. So it goes sideways too, to make sure that there's no fragments hiding behind the pupil or in the angle. Sometimes it's not very visible, you can't see them. And now I'm doing the hydration of the wounds using the moxifloxacin, and so that this amount the intracorneal part will stay. The intracameral part will be washed as the aqueous comes in and refreshes. And this is the dropless injection, the Trimoxy.
Oh,
And that's it. We're done with bilateral femto laser cataract extraction in a few patients, and with dropless injection, Eyhance lenses with the Eyhance blended vision. The Eyhance blended vision is very useful because the Eyhance has a depth focus. So if one lens will be focused for distance and gives you intermediate at the same time, and everything in the middle between the distant and intermediate, and the other eye will be focused to be intermediate and close-up. So this way, with Eyhance blended vision, there's no gaps in the vision. So the vision is continuous, not like the old ways of doing monovision where the point focus at distance, point of focus at close-up, and nothing in the middle. And this way you have a complete coverage of the range of the vision without gaps, and eases the adaptation to the blended vision. And there's no gap, so the patient doesn't have to come close to the computer to be able to see it, because with the old ways of monovision, sometimes it's a problem. The intermediate vision is a problem, but here the intermediate vision is covered by both the distance lens and the close-up lens. Both of them are covering that area. Now I've put the Tobradex drops and the COSOP drops in the patient eye for post-op control of pressure. And I'm setting up the patient to move the wedge from underneath her knees and make sure she's okay and stable. We don't patch the eyes. We just put either shields or protective sunglasses to make sure that the patient is comfortable seeing, because we did bilateral, so the patient is walking out seeing, can see her. I just fogged the image because of the privacy, but you see her walking and seeing, and we test the vision immediately after and make sure everything is okay, and we'll be all set. Thank you for watching.